Hello and welcome to Lecture 13 in the Principles of Exercise Therapy PET series. This week we're covering exercise screening and outcome measures. So let's remind ourselves what physiotherapy is concerned with. Human anatomy and physiology, human movement and function, maximizing wellness and potential, minimizing disease and injury, and ultimately solving real-world problems. So our principles of exercise therapy, we remember this by the acronym ASPORT-BILLY: adaptation, specificity, progression, regression, overload, reversibility, taking time out, behavioral change, individuality, lifestyle integration, law of diminishing returns, and your responsibility. Okay, so exercise screening and outcome measures are effectively two different sides of the same coin. So we want you to explore the concept of exercise screening and gain an insight how it can be used in clinical practice, recall the contraindications, both absolute and relative, and the cautions or precautions for exercise participation. Then we're going to explore the concept of outcome measures, gain an insight how they can be used in clinical practice, and recall standardized examples for both subjective and objective outcome measures. So why do we do exercise screening? Your patients are going to be sedentary unless you deal with athletic communities, because modern life is sedentary. And it's not uncommon for people to go months, often years, without taking any planned or structured physical activity. And then as a consequence, many people do too much too soon. So they effectively overtrain and overload, which leads to a high dropout rate because they have a poor exercise experience. So no one's educated them about the simple progressions that they need to make, and we might have to regress an exercise to make it suitable. Now, we all know the benefits of exercise massively outweigh the risks, but by a considerable margin. However, we've got to recognise that some individuals may have an unacceptably high risk associated with starting to exercise, and these are the guys and girls that we've got to be cautious of. So we've got a flow chart here. So we've got the sedentary individual, and we can either decide to take them into the low intensity activity, or if they've got an athletic background, we can give them the higher intensity stuff. But we're always going to do a self-assessment of risk. Okay, if there's no risk, okay, then they're eligible. If there is a risk, then we need to be screened by a doctor, okay, who's going to take a detailed history, a physical examination, create a risk score, and potentially do an ECG. So we've got to think about our high risk group, okay. We might have to send them on to exercise testing, where they could have a positive or negative score, and ultimately we want them to be eligible to exercise, okay. We don't really want them to have further evaluation unless they, of course, really need it. But we want everyone exercising as quickly and as soon as possible, because that's what gives them the good stuff. So why do we screen? So overall, there's a risk of cardiovascular or cerebrovascular events, so either a heart attack or stroke or sudden death during physical activity. Okay, the risk is there. It's very low, but it is there. And these are going to be related to respiratory or metabolic systems, and may occasionally involve other physiological systems as well. So the physiotherapist is going to gather as much information as we can about their state of health or the disease status, and do everything we can to reduce the possibility of a problem occurring during exercise. However, there are no guarantees that an adverse event might occur. Okay, but we minimize and manage that risk. So what is exercise screening? So before we do any sort of physical activity, we do a pre-exercise screening, and it's used to identify medical conditions which put people at higher risk of an adverse event happening. It's like a filter or safety net that's used to determine the potential benefits and also the risks for that individual. We've got to make sure okay, that the risks don't outweigh the benefits. So we've got this medical screen, okay. If they fail the screen, okay, then they get referred back to their doctor, who will then have to do a clearance for exercise, and we're going to have to treat that problem. But 9 times out of 10, they'll be fine. We then do our fitness assessment, metabolic assessment, okay, behavioral assessment, and then optimal fitness program based on science and medicine. Okay, so there are contraindications to exercise. So these are absolute no-nos to exercise when we say they're absolute. Okay, because the risk of injury or even death far outweighs the benefits of exercise. And then there are relative contraindications that are a little bit more flexible. So usually some accommodation can be made to allow the person to exercise. However, they serve as a warning to look out for complications. So contraindications to exercise, we basically break it down to 8 areas. So new or uncontrolled arrhythmias of the heart. Okay, resting or uncontrolled tachycardia, the heart beating too fast. Uncontrolled hypertension. Okay, so blood pressure is not controlled. Okay, symptomatic hypotension. Okay, so the blood pressure is low and they faint or black out. Unstable angina, again to do with the heart, and that will be recognized by chest pain. Okay, unstable or acute heart failure, which is a failure of the heart to pump enough blood around the body. Unstable diabetes. Okay, so you can't stabilize their blood sugars to do with insulin and glucagon ratios. Okay, and then febrile illness as well. So the Physical Activity Readiness Questionnaire is known as the PARQ, and it's designed to identify a small number of adults for whom physical activity may be inappropriate or need to have medical advice before they get started. It's evidence that you're complying with your duty of care to look after the patient, and it's creating that safety net or that filter before exercise begins. It's quick, easy, and it's non-invasive. So there's what one looks like, okay, and this would be an adult pre-exercise screening tool that just highlights anything you need to worry about. It is subjective, so do remember that. So the questions, if we go back, the questions, for instance, number 1, has your doctor ever told you that you have a heart condition or have ever suffered a stroke? You're going to know if you've got one of those two, okay? So the American College of Sports Medicine has designed a risk stratification, dividing the risk into 3. So low risk, okay, young individuals who are asymptomatic and meet no more than 1 risk factor threshold for coronary artery disease risk factors. Okay, this will be the majority of your fitter patients. Moderate risk, older individuals, those over the age of 45 if they're men, 55 if they're ladies, okay, or who meet 2 of the thresholds or more for the risk factors. Okay, and then category 3, which is your high risk category. These are known cardiovascular and pulmonary disease patients. Okay, they might have metabolic disease such as diabetes, or they've got more than 1 sign that suggests that they have these diseases. So low, moderate and high risk categories. So we've obviously got to get informed consent. We can't just make people exercise. We're not in the military. And we've got to know the degree of exercise supervision that they require. They might require very close supervision initially and then just occasional prompting after they've gained the skill. We've got to explain the benefits and the risks of exercise participation so that patients can make a balanced choice. We've got to go through the steps or procedures that will be followed in an emergency situation such as a fire. We've got the responsibilities of the patient. Okay, so they've got to report their own symptoms, and we really want them to comply with the exercise program. No good lying, say they've been doing the exercise at home. When they come into the class, they're clearly not fit. And it's a statement covering confidentiality and freedom of consent to participate in the program. Okay, so precautions to exercise. Contraindications, absolute and relative. Okay, and then we've got precautions. Okay, so the patient safety is part of clinical governance, and before we exercise our patients, we've got to make sure, okay, what's their hydration status like? Have they had an alcoholic drink within 2 hours? What's their nutritional status like? Have they just eaten a big meal, for example, and then they're coming to exercise? We'd obviously do a blood pressure and heart rate check at rest, and making sure they're wearing appropriate clothing and footwear. Okay, so I had one gentleman turn up at my cardiac rehab class wearing a 3-piece suit. Okay, that was inappropriate at best. Footwear, you don't want any comedy sort of footwear. Okay, so no high heels. Training shoes are the ideal. So during exercise, you've got to make sure that your patient feels okay with regard to getting out of breath and whether they're feeling any pain or not during the session, and create some strategies that they let you know they are feeling unwell, or they just stop during the session. They can stop at any time. After the session, you're going to remind your patients to have something to eat, remind them to drink lots of water, and you might do a check post-exercise of blood pressure and heart rate just to make sure that they've come down to those resting levels. So outcome measures. So now we've covered exercise screening, we're going to go on to outcome measures. So it's really important, okay, that we look at the WHO's design of a health condition. Okay, so we've got impairments. Okay, impairments are to do with body structure and body function. Then we've got activities. Okay, and the patient might have activity limitations, and then consequently they might also have participation restrictions based on personal factors and environmental factors also. So this is important because this is how we talk of things. We talk of impairments, we talk of activity limitations, and we talk of participation restrictions. Okay, so outcome measures. They're going to measure the level which measurement is required. For example, which impairment, what activity, what participation. And then the type of client and conditions treated. For example, might be neurological, might be musculoskeletal, could be the amputee community. The rehab setting could be in the community, could be in the hospital. Okay, could be just you as the physio on your own, or could be part of a bigger multidisciplinary team. How much time have you got with the patient? Other external factors, and the purpose for which the data is required. Might be part of audit, research, or service improvement. Okay, these are all things that outcome measures cover. So basically there are two types of outcome measure: a subjective outcome measure and an objective outcome measure. Subjective might be something like patient reported, and like a questionnaire. Okay, they can be highly validated, but they are subjective. And then objective, it's testing something specific, and it might be to do with a component of fitness such as range of movement, strength or endurance, or balance and proprioception. Could be a motor pattern assessment, or could be a functional task. Okay, but very clearly here, okay, one is practical, the other is patient reported. So for example, pain here, we've got the visual analog scale of pain, where we've got 10 centimeters here, and they mark where they're getting their pain. Okay, so that's roughly about an 8.5 out of 10. Or we could use the numerical rating scale, okay, from 0 to 10. Very subjective. Then outcome measures, we've got to test the particular aspect of function that it reports to test. So it's the validity, and the results should be the same or similar regardless of who administers the test or when it is administered, and that's reliability. So we've got to make sure that the test tests what it's meant to test, and that's the validity, and then we've got to make sure that we can repeat it, which is its reliability. And finally, the test should scale and change over time wherever it is being tested. Okay, and this is due to the responsiveness. So it's got to pick up the changes in that test. Okay, and we might refer to that as the sensitivity. Okay, outcome measures must be valid, reliable, sensitive to change, clinically useful, feasible in any given setting. They've got to be quick to use and require minimal equipment. Okay, if they're not any of these, then the clinicians simply won't use them. So what are we measuring? Could be measuring range of movement, okay, isometric strength, not power, okay, local muscle endurance, balance and proprioception, functional ability, and it's about creation of a baseline of which against to measure improvement. So for example, here we are, single leg squat as a nice outcome measure. Okay, we've got a nice straight line that we can draw on our chart, okay, between the mid toe, okay, knee and hip alignment, and here we can see, okay, this clear knee valgus there is massively out there. We could measure that using the tool, okay, and that gives us an objective outcome measure. Okay, so this is part of the qualitative analysis of single leg loading, okay, where we get someone to just do a single leg squat, okay, a single leg step down, and then a single leg hop for distance. Okay, so 3 strategies: a squat, a hop, okay, and a step down. So we're going to have a look at their arms, have a look at their trunk alignment, have a look at their pelvis, okay, have a look at their thighs, their knee position, and their steady stance, okay, between left and right, and that will give you a score. And that's by Dr. Lee Harrington and his team, okay, at the University of Salford here. Okay, so by the end of the lecture, we should now have explored the concept of exercise screening. We've gained an insight into exercise screening and how it can be used in clinical practice, okay, and we're going to recall the contraindications, both absolute and relative, and the precautions for exercise prescription and participation. We've explored the concept of outcome measures, both subjective and objective. We've got a good idea how they can be used in clinical practice, and we've recalled how the outcome measures needs to be standardized for both subjective and objective measures. Thanks for listening. Okay, we've got a list of references here. If you want them, we will see you on the next podcast.